Good afternoon. My name is Angel, and I'll be your conference operator today. At this time, I would like to welcome everyone to the National LAN event. All lines have been placed on mute to prevent any background noise. After the speaker's remarks, there will be a question-and-answer session. If you would like to ask a question during this time, simply press star, then the number 1 on your telephone keypad. If you would like to withdraw your question, simply press the pound key. Thank you. Jerry Henniker, you may begin your conference.
Good afternoon, and thank you for joining us for the National Learning in Action Network, or LAN event. We are very happy to have you with us today as we discuss the important topic of immunization, everyone's responsibility. My name is Jerry Henniker. I'm a Program Manager for Stratus Health and the Quality Innovation Network National Coordinating Center, or QUIN-NCC. And again, thank you for joining us in the WebEx Event Center. I want to go through just a few reminders and housekeeping items before we get started today. If you haven't already done so, you will need to access your registration confirmation email and unique registration ID to log into the WebEx. My colleague, Marilyn Ryerson, also with Stratus Health and the QUIN-NCC, will be monitoring our WebEx chat board, so please be sure to participate as we go along, and feel free to ask any questions through chat. Slides, resources, and recording for today's session will be posted on QIOprogram.org under the News and Events tab. And also, some of the resources that you're hearing about today are already posted here. Also, if you want to visit the event page on the QIO program website, you can find it here, and Marilyn will post that into our chat website. So let's start by reviewing today's agenda. First, I will be going over the continuing education, or CE, details. Then I will introduce you to each of today's speakers: Dr. Cherie Sutherland with the Centers for Medicare and Medicaid Services, Dr. David Kim with the Centers for Disease Control and Prevention, Dorothy Andre with TMF Quality Innovation Network, and she will introduce Dr. Kevin King, and Pamela Sykes with Mercy Clinic East, Nicole O'Kane with Health Insight Oregon, and then Jeff West with Qualis Health. There will be 2 separate facilitated discussions during today's call. One following Dr. Sutherland and Dr. Kim's presentations, and the second will be following the remaining presentations. And then finally, I will wrap up with a reminder to complete our post-event assessment and also let you know about some of our upcoming calls. I'd like to take a moment to remind our participants about the purpose of this important series of learning and sharing events. Without reading all the content here on the side, I am going to mention a few of our high points. The audience is very broad for today's call, and it's very inclusive of a variety of healthcare provider types, partners, and patients. Our purpose for today is to offer a virtual learning and sharing event, and with a focus on ideas and concepts related to healthcare quality improvement. For our expectations, we would like to ask that you all think of actionable ways to implement the ideas and concepts presented today, and to make a commitment to share the information with your own teams. And finally, we are always open to the new ideas and suggestions for topics to bring to the audience. So please feel free to send your ideas through the chat and/or through the post-event evaluation. You may also email the QUIN-NCC with any of your topic suggestions at QUIN-NCC@area-d.hcqis.org. And now to address the direct purpose of today's event, we will prepare healthcare quality improvement professionals to identify and implement effective healthcare strategies by exploring promising practices to improve patient and healthcare worker immunization rates. And we also want to make sure that this is as interactive as possible, and that can be very challenging. I know we have a pretty large audience today. So therefore, we ask that you commit as individuals to be attentive, active, and actionable. We want you to think about all the ways the content is relative to your work and to your priorities. We welcome your active participation by clicking the green check in the WebEx application. Also, you can click the conversation bubble. There you can choose yes in the drop-down menu, and also you can just put your answer in chat. Please say yes. We We are very excited today that we can be offering continuing education credits to all attendees who are participating in today's session. We offer credit to all physicians, physician assistants, registered nurses, nurse practitioners, dietitians, pharmacists, and pharmacy technicians. We also offer certificates of attendance. Should you have questions for additional accreditation types, we welcome those suggestions as well. Again, you can post those in chat or in the post-event assessment. In order to apply for continuing education credit, you must have attended the entire event today. You also need to complete the post-event assessment upon exiting this WebEx session. And please note that the continuing education evaluation only be assessed by following the application site hyperlink at the end of the post-event assessment. So you'll see that when you take that assessment. For technical assistance related to the CE process, please email Nikki Vacelis. And Nikki's email is Nikki Vacelis, and that's nikki.racelis @quincc.hcqis.org, and that will be posted there in chat for you all to see. A disclaimer for our partnering provider, which is CRW Associates. This activity awards 1.5 AMA credit hours for physicians and physician assistants. You may reference this slide for your full CE statements if you need to. Also, this activity also awards 1.5 contact hours for nurses and 1.5 continuing professional education units for dietitians. To follow are the accreditation statements for those entities. And then another disclaimer, we would like to report that the planners and faculty for this event, CRW and Associates, and Intelligence, do not have any financial relations to disclose, nor has any commercial support been received from this activity. And finally, here are the disclosures for our financial relationships. So, again, just a reminder to participate in the entire live activity in order to claim your continuing education credit. I think we've got everything covered here. We want to get an idea of who and what types of organizations are all represented on our call today. We invite you to respond to a poll indicating where you are working. So, WebEx, could you please open the poll for us? And while we are doing that, I am going to just review the session objectives. By the end of the call today, you should be able to identify at least 2 barriers to immunizing adults, describe how to leverage the multi-task practice transformation to improve immunization rates, identify at least 2 strategies to improve collaboration between clinicians and pharmacies, and describe at least 2 techniques used to improve immunization rates for healthcare workers. And it looks like our poll is wrapping up here and it's closed. We should be getting the results here pretty quickly. And Jennifer, do we have the results for the poll? And there they are. Thank you. And it looks like we have quite a few from our QIO partners today. Also, we're seeing hospitals, home health agencies represented, long-term care, skilled nursing homes. We've got a number of providers and practices on. So thank you all for joining us today in CMS. So with that, I'd like to now introduce you to our first speaker, Dr. Cherie Sutherland. She is an adult immunization subject matter expert for the Quality Innovation Network National Coordinating Center at the Center for Medicare and Medicaid Services, or CMS. Cherie will talk to us about the CMS quality strategy and provide an overview of CMS's efforts around improving immunization rates through improved tracking, documentation, and reporting. Dr. Sutherland, the floor is yours.
Hi, good afternoon, everyone. I'm so delighted to have this opportunity to speak with you a little bit about the work that CMS has been doing via the QuinnQIO contract around approving adult immunizations, more specifically focusing on those disparate populations. So just to give a bit of framing and an idea of kind of how that task order was sort of put together and what it's based on, I'm going to start out by giving a brief overview of the CMS quality strategy. And the CMS quality strategy is actually based on the Department of Health and Human Services strategy, which operates around 4 strategic goals, and they are to strengthen healthcare, advance the scientific knowledge and innovation, advance the health, safety, and well-being of the American people, and ensure efficiency, transparency, accountability, and effectiveness of HHS programs. And so based upon that, the CMS quality strategy was developed. And so the CMS quality strategy aligns very perfectly with the HHS quality strategy and guides the healthcare transformation activities from the federal, state, and local levels, including those that you all are working on in your community. And the CMS quality strategy prioritizes these 6 goals for success. So next slide. So the topic for today's call aligns with the 5th CMS quality strategy goal, and that is the one that centers around working with communities to promote best practices and healthy living. As many of you know, each year thousands of adults suffer serious health issues related to diseases that are vaccine preventable, such as the shingles, flu, and pneumococcal disease. There may be several factors that influences a person's decision or ability to be vaccinated, including those associated with individual behavior, access to health services, and the environments where people live. And as quality innovators, health professionals, and community members, we have the unique opportunity to improve lives through access to appropriate health care, deploying evidence-based interventions, and developing strong partnerships. It is through these objectives of the 5th goal that we seek to improve those immunization rates. And we would do this through partnering with and supporting our federal, state, and local public health improvements, improving access within communities, as well as promoting evidence-based community interventions, and also to increase the use of community-based social services and home and community-based services. Next slide, please. So, based upon that identified need, there is one task that is focused in the QuinnQIO contract around improving adult immunization. And so, as you can see, there are other tasks as well that are also aimed at prevention as well. And so we know that by getting an immunization, it can certainly help, especially our population that we're focusing on, Medicare beneficiaries with chronic disease management, because we know that not getting or failing to get that immunization can actually have very devastating effects on the beneficiary population, and more specifically, the minority and disparate populations that are already underserved. That may be because of access, it may be because of location, and it may be because of lack of knowledge as well. So next slide. So this task specifically looks at ensuring, and it's actually really much in alignment and based on the National Vaccine Advisory Committee standards for adult immunization practice. When this contract was being put together, there was a very strong and close collaboration with CDC to ensure that what CMS was doing was in line with what the national standards were, as well as having a real close working relationship with the National Vaccine Program Office at the HHS level to ensure that what CMS was doing was also in line with what the HHS goals were within the adult immunization plan as well. So with this particular piece of work from CMS, we are looking at ensuring immunization status is assessed by providers and documented appropriately, using certified electronic health records when possible. We are looking to improve immunization rates by providing education and technical support to providers, patients, and communities, as well as supporting providers as they utilize EHRs to begin or continue to report immunizations in the state immunization information systems and encouraging a focus on all patients. So both adults and children. Next slide. So these are some of the goals that we have set based upon the outcome of this work, based upon the work that QIOs are doing not only with providers, but also with beneficiaries directly as well, because as we know, beneficiaries can receive their immunizations in a variety of sources. So we wanted to make sure that we were able to capture that through this work. So QIOs have been charged with and are working with and have recruited providers as well as beneficiaries. And so by 2019, to align with the Healthy People 2020 goals, and you see those listed there, and also to ensure that 1 million previously unimmunized Medicare beneficiaries will receive pneumonia immunization as well. And so an important component of this work is to focus on reducing disparities among racial and ethnic minorities, rural Medicare beneficiaries, and dual eligible Medicaid and Medicare beneficiaries as well. And so next slide. So this slide sort of talks very briefly about the CMS quality payment program. There certainly is a lot more. If that's something that you're interested in, there certainly is a wealth of information out there on the CMS quality payment program, and I certainly would encourage you to seek out that information. The URL is located at the bottom of the slide. But previously, Medicare measured the value and quality of care provided by doctors and clinicians through a patchwork of programs that included the Physician Quality Reporting System, the Value Modifier Program, and the Medicare Electronic Health Record Incentive Program. And it was through these programs and through the law that Congress streamlined and improved these programs into one new merit-based incentive program. So all of those previous reporting programs have now been streamlined and are now included under what we call MIPS, or the Merit-Based Incentive Payment System. And there is an opportunity to improve immunization reporting in all four categories of MIPS if you kind of look at the slide: quality, resource use, clinical practice improvement activities, and advancing care information. So immunizations can be improved through all of those reporting categories. So, for instance, for the quality category, there are measures that focus on immunization rates for various age groups and vaccines. Strategies around succeeding in the program will focus on picking measures where it's already scoring high on low-hanging fruit, or if you aren't already high with your immunization rates, there are effective process improvements are put in place to get your rates up to the standards rather quickly. This can also lead to success in the clinical improvement activities category as well. And then, of course, immunizations can certainly assist improving resource use as well. And finally, in regards to advancing care information, reporting immunization data is an obvious choice. Clinicians can really choose to report customizable measures that reflect how they're using their electronic, because we realize there's no one-size-fits-all in their day-to-day practice. For example, how they collect their immunization status, but with a particular emphasis on interoperability and information exchange. And we do recognize that still exists a great challenge for many, is around that, interoperability piece between the IIS and the EHR. And so there are a lot of resources I know that CDC has placed specifically around that, as well as some other agencies as well. Next slide. And so while the quality payment program incentivizes providers to increase payment immunization rates, similarly, healthcare facilities can also receive incentives for reporting on immunization quality measures. So when we look at certain hospitals and inpatient psychiatric or rehabilitation facilities, they report on influenza vaccine coverage among healthcare personnel that are keeping our workforce healthy. And so the new adult vaccination standards really highlight the importance of collaborating between immunizing and non-immunizing professionals and being able to support the concept of an immunization neighborhood. And this term was coined by the American Pharmacy Association. And what it really seeks to do is to involve collaboration, coordination, and communication among immunization stakeholders with the goal of meeting the immunization needs of patients and protecting the community from vaccine-preventable diseases. And I know that our ClinQIOs are on the forefront of working within these immunization neighborhoods in order to best try and meet the needs of Medicare, specifically those disparate Medicare beneficiaries that may reside within those immunization neighborhoods as well. And of course, engaging the neighborhood in the goals is certainly desirable as we seek to increase assessments and reporting to the state registry has been successful with the ongoing support of CDC. So thank you so very much. I'll be hanging around for a bit if you have any questions.
Thank you so much, Dr. Sutherland. We appreciate your insights from the federal perspective and look forward to partnering with CMS and all of our participants on the call today in the future. It is now my pleasure to introduce our next speaker with us today. That is Dr. David Kim. He is Deputy Associate Director for Adult Immunization with the Immunization Services Division. Dr. Kim will provide an overview of the burden of vaccine-preventable diseases for adults in the United States, introduce the 2017 Adult Immunization Schedule, identify barriers to vaccinating adults, and describe evidence-based strategies to promote vaccinations for adults. Dr. Kim, the virtual floor is yours.
Well, thank you very much, and thank you for your kind invitation for me to join this panel to discuss vaccinations for adults. First, the necessary disclosures. I have none. And for this overview, I think the objectives were stated a few minutes ago. Vaccine-preventable diseases have a significant health and economic impact in the United States. In any given year, there are millions of cases of influenza with over 200,000 hospitalizations and 3,000 to 49,000 deaths, most of which occur among adults. Direct medical costs associated with influenza each season is estimated to be around $10 billion. If we add to this the economic burden associated with loss of work and life, then the costs soar to $87 billion each year. The impact of zoster, or shingles, and its sequelae, post-herpetic neuralgia, or PHN, is significant to the quality of life. PHN interferes with our daily activities, and mobility can lead to anxiety and depression, and generally lowers our quality of life. Each year, the shingles affects about 1 million people in the United States. The lifetime risk of shingles is about 1 in 3. For adults 60 or older, the risk of shingles is about 10 per 1,000 per year. For adults who are healthy and otherwise not at risk, the incidence of invasive pneumococcal disease, or IPD, is about 8 per 100,000. However, adults with heart, lung, kidney, or liver disease, or adults who are diabetic, smokers, or have alcoholism, are at 3 to 7-fold increased risk for IPD. For adults with immunocompromising conditions such as HIV infection or cancer, their risk for IPD is 20 times that of a healthy adult. In 2013, about 34,000 cases of IPD were reported, along with 3,700 deaths. Almost all of these IPD cases and deaths occurred among adults. We generally think of pertussis, or whooping cough, being a childhood disease. In 2015, 21,000 pertussis cases were reported. But adults were not spared, as 22% of these cases occurred among adults. The number of new cases of acute hepatitis B cases has gone down steadily over the years. Thanks to the Universal Infant Hepatitis B Vaccination Program, the incidence of hepatitis B among children is very, very low. But hepatitis B is still a problem among younger groups of adults. In 2015, about 3,000 acute cases of hepatitis were reported. But as many cases go undetected, the actual number of hepatitis B cases was estimated to be around 20,000. Human papilloma virus infections cause hundreds of thousands of cases of genital warts and can later lead to cervical, oropharyngeal, and other cancers that are preventable. Vaccines prevent illnesses and save lives. For influenza, the vaccine effectiveness varies depending on its antigenic match and the age and health of patients who receive the vaccine. When there is a good match, influenza vaccine effectiveness is around 60 to 70% for younger adults. The vaccine effectiveness estimates for the 2016-2017 influenza season is 43% for the predominant circulating strain H3N2, similar to recent years. The flu vaccine is good for the heart too. Studies have shown that an acute respiratory or influenza-like illness increases the risk of a heart attack twofold. Studies have also shown that patients with existing cardiovascular disease, the flu vaccine prevents acute MIs. In fact, the flu vaccine is as good as the use of cholesterol-lowering statins, medications to control high blood pressure, and smoking cessation in preventing MIs. The live attenuated shingles vaccine has 51% vaccine effectiveness against shingles. It is 66% effective against post-herpetic neuralgia and 80% effective against the most severe and prolonged cases of post-herpetic neuralgia. The 23-valent pneumococcal polysaccharide vaccine, or PPSV23, is 74% effective against IPD, but doesn't do much to prevent non-IPD pneumonia. But the 13-valent pneumococcal conjugate vaccine, or PCV13, provides 45% protection against pneumonia. In addition, PPSV23 provides additional IPD protection against pneumococcal serotypes that are not in PCV13. And that's why PCV13 and PPSV23 are used in combination. I mentioned earlier that there were 21,000 cases of pertussis reported in 2015. Vaccinating pregnant women with Tdap is 90% effective in preventing pertussis in infants who are too young to be vaccinated. This table shows the vaccinating pregnant women during pregnancy prevents more infant cases, hospitalizations, and deaths compared to vaccinating them after pregnancy. Hepatitis B vaccination also has a very high effectiveness. It is 90% effective upon completion of the 3-dose series. The adult immunization schedule is updated each year and represents the current policy of the Advisory Committee on Immunization Practices, or ACIP. The schedule is also approved by the American College of Physicians, the American Academy of Family Physicians, the American College of Obstetricians and Gynecologists, and the American College of Nurse Midwives. The adult immunization schedule is made of a cover page that contains important general information, recommended vaccinations by age, recommended vaccinations by medical condition and other indications, 2 pages of notes and accompanying figures that accompany the figures, and this is a page 2, and a table of vaccination contraindications and precautions. I realize that I'm actually speaking to an informed audience, but I'd like to take this opportunity to go over the main ACIP recommendations for adults, along with the 2017 updates. Influenza vaccination is recommended for all persons 6 months of age or older, unless contraindicated. Due to the live attenuated influenza vaccine, LAID, low effectiveness against influenza A, H1N1, TDM09 in the U.S. during recent seasons, the ACIP recommended that LAID not be used for the 2016-2017 influenza season. After considering additional data, the ACIP also modified flu vaccination recommendations when there's egg allergy. Patients with any egg allergy, mild or severe, can receive any age-appropriate inactivated influenza vaccine, that's IID, or recombinant influenza vaccine, RID. For patients with severe egg allergies, such as anaphylaxis, the vaccine should be administered in a medical setting as a precaution. Adults who have not received or don't know if they received the tetanus, diphtheria, acellular pertussis vaccine, Tdap, should get it now. Then get a TB booster every 10 years. Regarding Tdap for pregnant women, The ACIP reviewed additional data and recommends that Tdap should be given during every pregnancy, preferably early in the gestational period, 27 to 36 weeks, for the mom to produce higher antibody levels for transfer to infants. The ACIP recommended that females through age 26 and males through age 21 receive 3 doses of human papilloma virus vaccine if not previously vaccinated. Additional data indicate that adolescents who received 2 doses of HPV vaccination before age 15 developed immunity comparable to 3 doses. So the recommendation has been revised to give 2 doses for adolescents younger than age 15. Adolescents and young adults who did not start their HPV vaccination series before age 15 should get 3 doses. But what about those who started the HPV vaccination series before age 15 but didn't finish it? Well, if they received only 1 dose or received 2 doses less than 5 months apart before age 15, then they should get 1 additional dose. If they received 2 doses at least 5 months apart before age 15, they're considered adequately vaccinated and don't need any more. The recommendations for hepatitis B vaccination have not changed. For 2017, examples of chronic liver disease such as hepatitis C infection, cirrhosis, and alcoholic liver disease have been added. The recommendations for hepatitis A vaccination have not changed. For pneumococcal vaccination, 2 changes have been made to the existing ACIP recommendations. The serogroups A, C, W, and Y pneumococcal vaccine, that's ACWY, is recommended for adults at risk, such as those with asthenia or complement deficiencies and those in outbreak settings. This group now includes people with HIV infection. The serogroup D pneumococcal vaccine, MenB, may be administered to healthy adolescents and young adults aged 16 to 23. There are 2 types of MenBs on the market. MenB FHBP, that's Trememba, can now be used as a 2-dose regimen for this population. For those at risk, a 3-dose series of Trememba is still recommended. The other MenB, MenB4C, Bexero, remains a 2-dose regimen. The ACIP does not have a preference for one MenB over the other. There are no changes in the pneumococcal vaccination recommendations. And of course, you know that the recommendations are complex, but I tried to distill it down to this. There are adults at highest risk, so meaning those age 65 or older, and those who are immunocompromised, and those at high risk, and that's those with chronic disease or alcoholism or who smoke. Those at highest risk need the 13-dose pneumococcal conjugate vaccine, PCV13, followed by the 23-valent pneumococcal polysaccharide vaccine, that's PPSC23. Those at high risk who need just PPSC23, and when any adult reaches age 65, he or she needs a dose of PCV13 if he or she has not already had it, and a dose of PPSC23. Compared to pneumococcal vaccination, doctor vaccination is straightforward. For adults 60 or older, 1 dose of the live attenuated vaccine is recommended unless the patient has a contraindication such as severe immunodeficiency. Adult vaccination coverage in the United States is very low. The data from 2015 shows modest gains in pneumococcal vaccination for 19 to 64-year-olds with high-risk conditions, Tdap for 19 or older, and shingles vaccination for 60 or older. But the overall vaccination rates for adults remain very low, and racial and ethnic disparities persisted. The full report will actually be released later this week. At a glance, this figure should tell the story about the low vaccination coverage rates for adults in the United States. That's this one. And we compare the figure for adults in the previous slide with the figure for young adults, for young children on this slide. Vaccination coverage rates for most vaccines for this age group are above 90% or approaching it. Comparing influenza vaccination coverage rates between adults and children, you can see the significant disparity. 60% for kids versus 42% for adults. Even among adults who have some type of private or public insurance, vaccination coverage was low. In fact, adults with health insurance who have had 10 or more visits with their physicians in the last 12 months still had missing vaccinations 24 to 89% of the time. If we ask adults why they are not up to date on their vaccinations, the most frequent response we get is that they simply didn't know that they needed vaccines as adults. To help close this gap, adult immunization partners and stakeholders are implementing the standards for adult immunization practice among healthcare providers, including pharmacists. The standards recognizes that although not all providers stock vaccines, provider recommendation is critical. The standards calls for providers to assess vaccination status of their patients at every encounter, strongly recommend the vaccines they need, either administer the vaccines or refer them to a vaccination service provider, and document the vaccines received by the adult patients in vaccine registries or immunization information system. This figure shows the rates of influenza vaccine uptake by pregnant women by the interaction they had with their providers. Starting at the bar on the far right, when pregnant women reported that they received no recommendations for a flu shot from their provider, 16% ended up with the flu shot. When the provider said, you should get the flu shot, 46% actually got to get the flu shot. And when the provider said, you should get the flu shot, now roll up your sleeves, 70% ended up with a flu shot. In spite of the major influence that providers have on their patients' decision on vaccination, in a recent CDC survey, adult patients generally reported that they are receiving low levels of care that reflect the standards, regardless of clinical specialties of their providers. But if we ask the providers if they are implementing the standards, their reports are quite different. This figure compares what the providers and adult patients report when asked if they give or receive recommendations for vaccines, respectively. Clearly, there's a big difference. Improving vaccination coverage rates for adults is really not rocket science. It's about patient education and it's about provider recommendations. The Community Guide, which reviewed available evidence on improving adult immunization, outlines proven strategies, including making system changes to make vaccination a part of routine patient flow. Interventions such as standing orders, provider reminders and feedback, patient reminders, and recalls are proven effective strategies. Every state has an immunization coalition, and many have adult-specific immunization coalitions. I suspect that many, if not most of the participants in this webinar belong in a state or local immunization coalition. And providers, of course, have a key role. They give strong recommendations and use the vaccine registry. The single most important factor in whether an adult patient gets vaccinated or not is a recommendation from his or her healthcare provider. Of course, making system changes to reduce barriers enables improved vaccination delivery. Healthcare systems and providers cite financial barriers stated in different ways as the most important factor. Other considerations include quality measures on adult vaccination and a system that champions vaccinating adults. There is a lot of resources available to implement the standards for adult immunization practice, including education and training materials for providers and patients. There's a ton of resource materials from professional organizations, including information on proper coding and billing. And other very helpful resources, such as these maintenance of certification opportunities to make vaccinating adults a winning proposition, professionally and financially. There is a national coalition on adult immunization called the National Adult and Influenza Immunization Summit, Its goal is to bring together a wide range of stakeholders to identify and solve issues related to adult immunization. The summit's annual meeting will take place next week in Atlanta. We encourage you to join your state's coalition as well as the summit. The summit's website is on this slide. So in summary, I described to you that the high burden of vaccine-preventable diseases and the impact of vaccination among adults. Unfortunately, vaccines continue to be severely underutilized by adults. We can improve the adult immunization vaccination rates by talking to the patients and implementing proven strategies that work. Thank you for all that you do to promote vaccination for adults. And I switch this back to you.
Thank you, Dr. Kim. That was a wonderful presentation with a lot of information and resources. We're going to take just one, we have time for one quick question from chat. Do we have anything posted to chat at this time, Marilyn?
Thanks, Jerry. Wonder, Dr. Kim, with retail pharmacies providing many immunizations now, are you aware of any group that is tackling the need to encourage immunization information systems reporting in individual states? For example, CVS, Walgreens, Walmart, organizations like that?
The National Association of Retail Pharmacists, to which CVS, Walgreens, and other Safeway, Kroger, and other pharmacies belong, and pharmacists have a terrific program to promote the use of immunization information system or vaccine registry in documenting the vaccines that they administer. Now, there are some challenges in that IIS it's a state-driven initiative. There is no national coordinated complete system of IIS. They're all developed and run by state immunization programs, state and sometimes local. But pharmacists are a key cog in ensuring that adult immunization records get deposited in IIS. And retail pharmacists are actually leading the pack in this effort. So yes, there are national organizations, including the American Pharmacists Association and others including independent pharmacy associations that take significant pride in their ability to administer vaccines and documenting the vaccines that they deliver in their state's IIS.
Okay, great. Thank you so much. That is helpful. It's a work in process.
And thank you again, Dr. Kim. And we are going to move on to our next set of speakers. We will have time again towards the end of the call to ask more questions. And again, you always have your place in chat where you can post questions. Now it is my pleasure to introduce Dorothy Andre, Director of Clinical Operations with Primaris in the TMF Quality Innovation Network. Dorothy will introduce her colleagues with Mercy Clinic East and will provide some context around their joint efforts in immunization. With that, Dorothy, I turn it over to you.
Thank you so much. It is really my pleasure to be on the TMF LAN event today. It's an honor to introduce our Mercy presenters. We've worked with Mercy for a number of years. They're going to tell you about their great best practices that they have used, and it's taken a little while. This has been a journey. So without delay, the next slide. We are part of the TMF QIN-QIO Regional Partner Group, and that's the QIN-QIO for our area, 5 states together, and Texas. TMF Health Quality Institute is our leader. We have Arkansas, Primaris, our organization, KPRO, and of course TMF all together working to find the right kinds of supports and expert technical assistance for participating providers across our region. Next slide, please. So there's the map, and there's all the QIN, QIOs in the country. You can see where that central green portion, and I know some following presenters are coming from some other 2IN2IOs, and that has been the reorganization that started us out in this 11th scope of work. Next slide. So without further ado, let me introduce Dr. Kevin King and Pam Sykes. Kevin is board certified in family medicine as part of a busy clinic in Stockwood, Missouri, which is a small community outside St. Louis. He joined Mercy Clinic in 2009 and got involved very quickly with the community to improve care provided by the entire clinic. He spends a lot of his time volunteering in services that provide care to uninsured and underserved populations locally and in other parts of the world. He is current co-chair of the Mercy Clinic Adult Primary Care Quality Safety and Value Committee, and he is one of the physician leads for the Adult Immunization Collaborative between Mercy Clinic and AMGA. And Pam Sykes is an RN who joined Mercy Clinic St. Louis over 18 years ago and is on the call today to support Dr. King, the son of the history of the vaccine work at Mercy Clinic. Pam has spent most of her time at Mercy furthering the clinic's efforts to provide comprehensive care to their almost 500,000 patients via quality processes and initiatives. Pam joined the Mercy team as the next step in her career toward population health care, a journey that took her from hospital med-surg nursing to home health to medical case management and finally to Mercy. And even in 1999, when they were leaders in population health in the St. Louis area. So I'm pleased to turn it over now to Dr. King and to Pam. Please welcome.
Thank you very much for that warm welcome. Pam and I work very closely, and she's been a great resource as I've been getting involved. She has headed a lot of what we're going to talk about today over time. We are proud of our Mercy heritage at the Sisters of Mercy, and in 1831, Sister Catherine Macaulay started providing clothing and food and then health care to many patients in Ireland, and they came over here in 1871. And we're going to talk about some of the things as Mercy's expanded in terms of our influenza and pneumococcal immunization rates and some of the initiatives we've taken that we've had success with in particular. Our group has grown significantly. We've got a slide next that'll show how many providers we've expanded from back in the mid-90s. We've got 4 acute care hospitals. We have a virtual care center that's providing care to those in our surrounding communities that have trouble getting to some of our satellite locations. We've got 283 physician practices. We're multi-specialty, a large primary care base with specialty care as well. We have 1,263 staffed beds, over 10,000 births per year, over 50,000 surgeries, over 58,000 inpatient discharges, and then 3.5 million outpatient office visits per year. And you can see our distribution in St. Louis and the surrounding communities, but we are part of a larger Mercy system that extends down into southwest Missouri and northwest Arkansas and into Oklahoma. When we pulled our data back in 1999, which Pam was a strong part of, we were using audits. Everything was paper charts, and they would pull out, individual providers' data, and, flu vaccine rates back then kind of were similar to some of the trends. I feel like what I've seen is influenza rates were much higher in the late 90s, 81%, and then pneumococcal vaccination rates were at 60%. And then over time and numerous different initiatives, we were at 60% last year for influenza vaccine rate and 82% for pneumococcal vaccination rate over the age of 65. Our Missouri numbers from the year before hopefully offers a little bit of comparison, albeit a different year, at 41% influenza and 73% pneumococcal. There's about 8 bullet points over the next few slides, just for point of reference for everyone here. We had initially, as soon as Mercy Medical Group started, internal auditors were hired to help take part in kind of early stage kind of population management, and influenza and pneumococcal immunization rates were always two that were used in our quality committee. We also were doing mammograms and colonoscopies back then. The flu reminder letters were starting to be sent out at that time, with a standard stamp and self-addressed envelope. In 2004, a big initiative in the hospital took place where paper form was at the front of the chart for both pneumococcal and influenza, so that anyone that came in would have just kind of a standing order for a vaccination. As our pharmacy departments have expanded, they've also offered influenza immunizations and a number of kind of community efforts. For example, in September, October, there's always a Saturday where we immunize all our pregnant patients. EMR was obviously a huge step for us. We started with one system in 2003, and Pam, you may have to correct me, but I think they went to another one in 2005 and then another one shortly after, and we're on Epic now. But it's really helped allow us to pull our data more effectively, utilizing other resources as well. Best practice alerts populate in the hospital for the pneumococcal vaccinations. We have a health maintenance tab. Many of you may be on Epic that we use, and then we've expanded a daily visit planner that populates every time we have a patient over 65 or anyone on any of our Medicare ACO plans that will flag if they're due for a flu or pneumonia. We're also very lucky in some ways to have a bidirectional feed between our EHR and our state immunization registries. One issue even with that, our St. Louis County Health Department still does not upload theirs in there, so there's still a lot of room for improvement with those plans. We also get individual reports for our practices, how we're doing with our vaccine rates over time. We've had a lot of educational efforts over time. I'm not going to mention all of these. As going through currently, we're working on a kind of brief PowerPoint, 1 to 2 pages to help clarify, high-risk pneumococcal or Prevnar 13 vaccination and at-risk vaccination, mainly for our staff, just to kind of navigate some of the confusion around that. We also have all our storage and handling equipped with medical grade refrigerators and the remote temperature monitoring. And they do go off every once in a while in the middle of the night, and you get cold. We have influenza vaccination requirements for our coworkers. This past year, we're at 98%, and we have let's see here, 16,000 coworkers in our East community. So we felt that is a great initiative for the health of our patients, but also it serves as a good model for our patients when they know that we've all been vaccinated. And I know I kind of flew through a lot there. I think I will pass the ball back over to Nikki and lead any questions that you might have.
And this is Pam Sykes. I was asked to address, when you saw the slides with our statistics, it looks like our influenza vaccination rate has fallen. That is what we're actually able to pull out of our reporting. We did a phone survey several years ago when we saw our rates actually declining and found that the rate was staying steady. It's a matter of us being able to pull that information into our EHR, either from the state registry, et cetera. And as Dr. King noted, the public health departments are just beginning to report into the state registry, and I think we'll see our rates increase significantly. But our research shows that we haven't fallen as low as it appears. But St. Louis has had a long-term culture of not getting flu vaccines at a primary care physician office. In fact, you can even get them in donut shops here. So it's a matter of capturing where all our patients are receiving those vaccines.
And we are,
Go ahead, Dr. King.
I was just going to mention, patient-reported data is one thing we're also kind of tackling, sending out an annual flu reminder and working with our IT department to get patients to be able to enter that themselves to kind of maybe close that loop as well. And I will stop. Thank you.
Thank you so much, Dr. King. Also, Dorothy and Pam, that was a really wonderful presentation. Now it's my pleasure to introduce our next speaker, Nicole Kane. She's Director with Health Insight Quality Innovation Network in Oregon. Nicole will discuss their multi-task practice transformation approach to improving immunization rates. Nicole, the floor is yours.
Thank you. And it's been a great summary so far to look at not only national flu and other immunization initiatives, but to look at different settings. How does that look at a hospital in Missouri? What does that look in an outpatient setting in Oregon? So I want to talk a little bit more about increasing immunization rates. What I'm going to focus on in the next 10 minutes is specifically looking at how Health Insight decided to regroup and to reinvigorate our initiative on immunizations, especially as we started to look at how our practices were receiving information and how we were interacting with those practices and finding out what they needed. Next slide. So again, overview, I'm just going to speak for about the next 10 minutes on talking about practice transformation that's really in an outpatient setting, but specifically looking at pharmacies and outpatient clinics and looking at how we can increase immunization rates in adults in those settings. And then talk a little bit about the target between a pharmacy and a clinic and how at the beginning we talked a little bit about immunization neighborhoods, how we can make sure that if there's a pharmacy and a provider in that neighborhood, how are they collaborating and what does that look like for the person who needs to get vaccinated. Step back a minute for those who are not aware, Health Insight is a quality improvement organization. We are the CLIN for the western states, Nevada and New Mexico, Oregon, and Utah. We also have some end-stage renal disease networks in Network 16 and 18, and we do quite a bit of work around health information technology, regional extension centers looking at national data around Medicare and looking for quality improvement opportunities in those data sets. Next slide. So clinical practices in general, I'm talking about outpatient clinics. These can be 1 or 2 doctor clinics as well as larger health system clinics. We know that there has been a lot of changes going on in the way that doctors get paid. We know there's a lot of policy changes around people getting insured and how that insurance gets reimbursed. We know that there was a lot of national and state initiatives, and we were hearing from our clinicians that those programs aren't always well aligned. So we wanted to make sure that when we were speaking to clinics, when we were helping them improve their immunization rates or whether we were improving their screening for cardiac disease or whatever the topic that the 11th scope of work was having us work on, we wanted to make sure that we were being effective in getting that clinical work to the clinicians who needed it when they needed it. And we wanted to make sure that that was longitudinally available to them, not just at the beginning of the contract, but throughout the contract, and making sure we'd help them get a full transformation of their clinic. And next slide. At the same time, of course, as a QIN, we were going through a lot of transformation. I think I can probably speak for everyone who's part of the quality improvement work over the last 3 or 4 years. Our contracts changed. We became more regionally focused. There's a lot more recruitment fatigue where programs are more involved with many quality improvement programs. So we also wanted to have a strategic direction. We also wanted to make sure that as clinics were becoming more effective, that we were there to help them and support them in the timing and in the way that they need that, whether that was in improving their workflow, whether that was helping them with their electronic health records and reporting, a lot of different ways in which we can help them. And obviously, this doesn't just relate to immunizations. We're trying to get them to transform their practice across their system and at the same time making sure that they're getting immunization work done for their patients. Next slide. So what we did is we basically realigned the way that we were delivering our service. So in the past, with maybe in the 10th scope of work or other quality improvement contracts that we worked on, we would be more likely to go out and talk to a clinic about immunization. What we did with the 11th scope of work is we reintegrated our teams where each region of our state or of our quality improvement network has a community. And within that community, there's one point person, there's one transformation expert for that outpatient setting. So rather than having an immunization expert go to visit that clinic, they have one transformation expert. That expert then has access to expertise, whether it's around immunization, whether that's, again, I mentioned cardiac disease, diabetes, whatever that might be. So rather than having a clinic see a specialist on immunization, they're seeing a specialist on transformation. These account managers, we've done a lot of training and retraining around how they deliver this information, and very importantly, how we assess what our clinics need. And that's where we really get into the immunization package that I'll talk about next slide. So when we went out and started focusing with clinics and looking at clinical practices around immunizations, what we found was what Dr. Kim said earlier, looking at ways in which we can make sure that a clinician recommends an immunization every time there's a possibility. So whether that's at a wellness visit, whether that's at a flu clinic in the fall, whether that's the timing related to standing orders in their electronic health records, all of these things help opportunities. So every time there's an opportunity to bring up immunizations, whether it's a poster in the waiting room or whether that is through the well visit checks as they're seeing the clinician, always an opportunity to remind. We also got a lot of information back from clinicians around helping other staff to be able to talk about immunization. So the card that's on your screen here is an example in English, and we have it in Spanish as well. But non-clinicians, helping them be able to frame the importance of immunization and having information available if someone wanted to start a conversation in the clinic. That leads into the next slide, our pharmacy partnerships. So much of the work that's being done, as I described, is a transformation specialist going into a clinic. And part of the work that happens as that person is having the conversation with the clinicians is, do you vaccinate? Are you currently vaccinating? If those clinics are not vaccinating, which we're finding more and more in the western states, that clinicians in a primary care setting are choosing not to vaccinate, then we want to make sure we connect them with pharmacies in the area that are vaccinating. Again, getting back to that immunization network. Making sure that within that neighborhood, whether it's in a small town in rural Utah or whether it's a larger urban area, that every clinician knows where to refer their patients. This on the slide that you're looking at right now is an example of something that we developed for community pharmacies. Again, in having conversation in those settings, we found that there was a good opportunity for technicians to begin the conversation about immunizations. Remember, we mentioned every time that there's an opportunity to mention and to recommend increases the chance that that person will get that vaccine. So the way that this works in the pharmacy, and we've really just started to partner, we're working with Clover pharmacies in our western states and looking at how the type is a little bit small so you can't see it, but it's basically a way for a technician to practice what they're going to say to the patient when that person comes to pick up their prescription. So some screening occurs ahead of time. There's a flag that brings up that the person might be eligible for a vaccine. And then basically the technician reads the script. Our pharmacists strongly recommend pneumococcal or a shingles vaccine, and it looks like you may be eligible. Would you like to talk to our pharmacist today about getting that vaccine? So again, opening that door. If there's some pushback or the person doesn't necessarily want to talk to the pharmacist right then, often it's related to they don't have time or they're in a hurry, then the technician relates information about when they are more likely to be available for vaccine or when there would be no waiting. So again, prompting that person, using nudge behavior to help that patient say yes to that opportunity. And if they can't say yes today, maybe they can have a conversation with the pharmacist today that helps them to get to yes. If they don't have time to have a conversation with the pharmacist today, they can at least take information with them that helps nudge them further, helps them perhaps to say yes in the future. The way that we've been able to partner and put this data together between pharmacies and our clinicians is through the state of Oregon, our IIS data. So in the state of Oregon, pharmacies are required to include their immunization whenever they give a immunization, it goes into the registry. So they have a pretty good effort to capture most of the immunizations that are occurring in our state. I think I'll have you go to the next slide so you can take a look at some of the graphs that we've put together. So essentially we have statewide data. We also have data by vaccine. So I don't have flu vaccine on here because we're currently in the process of looking at our flu vaccine and putting things together for our fall flu immunization programs. But this is an example of the pneumonia and the zoster. So top two graphs are statewide averages for the last 3 years. And then the bottom graphs show who's doing the immunizing. So not only, you can see the over time, but that providers in private practice in the past were doing quite a bit of immunizing, especially in 2015. And we're seeing a trend now where we're seeing more and more immunizations happening at pharmacies and fewer happening at some of our provider offices. So again, a great way to use this data, not only to start a conversation with providers and pharmacists who there may be a provider who's not vaccinating, but in that same town there may be a pharmacy that is, making sure that those communities, those neighborhoods are getting built and that they're getting referring patients, but also to look for opportunities and look for gaps. By looking at the statewide data across the pharmacy, we can, of course, see that there's some pharmacies that do better than others. What are the practices that are happening within that pharmacy? For example, we're piloting this nudge behavior with the technicians, seeing if that can help grow their ability to do higher immunization rates. We know that there's some pharmacies that have a little bit more comfort level with starting those conversations, so having some of this data and having some scripts to help the technicians with that training, we're hoping to move those immunization rates for those pharmacies. And with that, I think just for the sake of time, we'll open it up for questions and can be glad to address any questions that anyone has.
Thank you so much, Nicole. And actually, we're going to hold questions until after our last speaker. And so at this time, I am pleased to introduce our final speaker, Jeff West, Quality Improvement Principal with Qualis Health. Jeff will provide an overview of the techniques that were utilized by Manicare Salmon Creek on healthcare worker flu immunization. So, Jeff, I turn it over to you.
Thank you very much. I am presenting this on behalf of David Brantley, the Director of Nursing at Manicare Salmon Creek in Vancouver, Washington. Next slide, please. Qualis Health is the Clean QIO for Washington and Idaho. Next slide. And these are the major points I want to cover. You could consider these the strategies for improving flu vaccination that Salmon Creek used. First, they made the case for vaccination. They addressed the safety concerns. They facilitated and incentivized people to get vaccinations. And they had consequences for non-participation. Next slide, please. So when you're talking about making the case, the way they made the case primarily is by appealing to healthcare workers' inherent motivations. Healthcare workers want to take care of residents, their patients. They want to take care of their own families, and they want to take care of themselves. And appealing to that rather than pushing hard on compliance and adherence with rules and regulations was a better way to motivate people to participate and get the immunizations. Next slide, please. In making the case, of course, you have to make the case that it's effective to get the flu vaccination and that it's important. So pointing out that the flu is serious, sometimes fatal, more so for the vulnerable elders and youngsters, that more so for those than for the mostly healthy adults that comprise the healthcare workforce. Also pointing out that the vaccine is not, even if not perfectly matched to a circulating virus, still works to decrease the severity of flu and the chance that you could spread the flu to others. I think it's important that in the case of Salmon Creek, they also appeal to the population health perspective, pushing people to look at the authoritative information on flu vaccination and not just rely upon personal or anecdotal evidence. So even if your own personal experience of flu or flu vaccines did not necessarily make the case for getting it for everybody, perhaps referring to the authoritative information would help you make that connection. Next slide, please. And then, of course, you have to address the safety of vaccination. Many people have heard about or think that there are large safety concerns with getting vaccinated for the flu, including that you can get the flu from the vaccination, and you have to address those concerns head-on without demeaning the people who have those opinions or in any way setting up a resistance to the information you're trying to give. As we all know, Guillain-Barré is one of those major potential side effects from a flu vaccination, but it's extremely rare. Egg allergies are no longer the same concern that they used to be in the past, as we heard earlier in this presentation. Only if there were a severe reaction to an egg allergy would you require monitoring in the medical setting. And most side effects that you could expect from a flu vaccination are actually pretty minor and not all that common. And again, well worth the benefit in terms of protecting vulnerable people that we're taking care of, ourselves, our family, well worth the benefit for decreasing the spread of flu. Next slide, please. Again, a large portion of our healthcare workforce are female, many of them of childbearing age, and so it's important to address this concern about pregnancy and vaccination. Flu is more severe for pregnant women and for women who have recently given birth. Flu increases the risk of complications, such as premature labor, and vaccinating pregnant women helps protect the baby for up to 6 months after birth. So these are all good reasons for people to put aside any concerns about vaccinating while pregnant or attempting to get pregnant. Next slide, please. Salmon Creek also did a very good job of facilitating and incentivizing the healthcare workers to get the flu vaccination. They made it easy. They provided it on all 3 shifts and 7 days a week, and that's very important. They led by example, making sure that the management, the DON, the administrators, charge nurses, and other folks got their shots at all staff meetings so they could be a public example of what flu vaccination was all about, what's involved. They provided snacks and treats for people who got flu vaccinations on site. It sounds like a small thing, but those of us who've worked in staff development and getting people involved in campaigns before know that those kind of tokens of appreciation go a long way to breaking down barriers and getting people to come and visit you. They also promoted friendly competition between units and facilities with prizes. They promoted collaboration with other community providers. As we know, in many situations, people in long-term care facilities work in a couple different facilities in an area. So getting a community to participate as a community was the strategy that Salmon Creek used, and it was very effective. And then again, of course, making the authoritative information about flu widely available within, paycheck inserts, on bulletin boards, and at nursing stations, wherever people might be able to pick it up and make use of it. Next slide, please. And then finally, there are true consequences for non-participation. These are not punitive. These can be explained in terms of the overall protection of vulnerable patients and adults, patients that we are taking care of. So stickers and pins were provided for anybody who got vaccinated. They could wear that on their uniform. It identified them as a vaccinated person for that year. The staff, the color changes each year, so you can see if it's a current pin. If you didn't have a sticker and you're a staff person during flu season and you're in a patient care area, you had to wear a mask. And the reason for that was not, again, punitive. It was to protect the multiple people we're taking care of. And you did that for the length of the flu season as determined by your local health department or the CDC. So those are the strategies that Santa used to improve their vaccination rates. They achieved a very high rate in the high mid-90s for a geographical area, the Clark County, Washington, for a number of adult assisted living facilities and nursing homes all put together. Thank you very much, and that's what I have to present.
Thank you so much for your presentation, Jeff, and thank you to all of our speakers today. We've heard about a number of great resources from all of the speakers, and I want to let you know that the NCC is creating a one-pager of these resources that will be posted to the QIO program website, hopefully by the end of this week. Now at this time, I want to open it up for questions and comments for the speakers that we've heard today. Dr. Kim with the CDC, Dr. King and Pamela Sykes from Mercy Clinic East, Nicole O'Kane with Healthsite Oregon, and Jeff West from Qualis Health. So I'm going to turn it over to Marilyn, our chat facilitator, to share about the conversation that's been happening in chat and questions that you have all posed.
Thanks, Jerry. First of all, there's a question for Dr. King. To what do you attribute your successful 98% immunization rate to?
This is Kevin King. Just the mandatory component of it. We had a form that needed to be turned in, and it was, relayed importantly that it was for the health of our community and our patients, and to continue employment, you would need to be vaccinated with flu.
Okay, great. And so a policy requirement upon when they first got hired?
For the flu vaccine, so this was all our, and forgive me if I'm wrong here, but this is for all our current employees. So it came down either from the office manager or, their individual units. And we had a good form that we would fill out, and those were, accumulated by our Human Resources Department to make sure everyone had it vaccinated.
Great.
And there were emails sent, and we had these weekly huddles in each of our groups where it was relayed that information. So.
Okay. Thank you so much. Angel, are there any callers in the phone queue at this time?
At this time, if you would like to ask a question, please press star, then the number 1 on your telephone keypad. We'll pause for just a moment to compile the Q&A roster.
Great, thank you. While we're waiting, Nicole, wondered if the script cards and the immunization intervention package that you talked to are available on your website.
We can make those available. My colleague is on the call. She's not in the room, but I know she's there, and we can make sure that those are available. What is the easiest way, or how do you usually share documents?
Yeah, thank you. If you would just send them to the NCC team, we'll make sure to include them in all of the resources with this call that will be posted to the QIOprogram.org website.
Right, we can do that. Thanks for your interest.
Thank you. Another question in chat. Oh, I'm sorry. Angel, was there anyone in the phone queue?
There are no questions at this time. To ask a question, please press star, then the number 1 on your telephone keypad.
And while we're waiting for that, wondered if any of the presenters on today's call have any early word on the live attenuated influenza virus for the 2017-2018 season.
This is David Kim with the Immunization Services Division at CDC. At the February ACIP meeting, progress on the LAIVs, possible possible recommendations for the upcoming influenza season was discussed, but the studies that are needed to make that decision were still pending at that point in time, and likely it was discussed by the voting members of the ACIP that the results will likely not be available in time for the ACIP to take action in October, and certainly not in time for policy discussions to be put forth for the ACIP at the June meeting. So, although it's not 100% for certain, chances are LAID will continue to be on hold for the 2017-2018 influenza season.
Thank you so much. Another question from chat that we received is, it is sometimes difficult for providers to ascertain their immunization rates, and wondering if there are any plans to create something like the comprehensive clinic assessment software application for providers to be able to establish their adult immunization rates.
This is David Kim again. I will take a stab at that, though the perspective that I have is one perhaps a bit removed from what really happens on the ground at the provider level or in the department level at the clinic. But this is where I get up from my IIS promotion hat and say the immunization registry is indeed a key. And not only does it provide a feedback mechanism for individual providers and clinics, and compare the results with what's going on elsewhere in the state or in the immunization program's jurisdiction, but you can also compare the information nationally and so on. But the key is having the information and being at that threshold where you have confidence that the information in the registry is comprehensive and informative. So our immunization program managers at the health departments, at the state level, and as well as the local and county levels, city and county levels, they've been working very, very hard to push the immunization information system out to providers and pharmacists. When I say providers, I am also including pharmacists in that discussion. And that is perhaps the best way to find out where you are in terms of your own healthcare system, whether it be that in a sole practitioner's office or independent pharmacy, or in a larger healthcare system, to be able to almost instantly figure out where you are, and with that information you can also approach the immunization programs at the health department for any assistance for example, in obtaining free vaccines to administer to patients who may not have insurance or patients who may not have vaccination coverage in their insurance. So there are multiple ways you can use this information for the benefit of the patient, and I think I can't emphasize this strongly enough that the RIS is the starting point for that. And if anyone has any questions about how to get into the IIS, then you simply need to contact your local health department immunization program, and you can be linked. Although there's some instances where there may be some wait. I will say I would like to just comment that Michigan as an example, has what they've been calling a report card. It's not really a card as much as an assessment of the immunization rates at the county level to demonstrate what the immunization status of the residents in the county as per information contained in the Michigan immunization registry. And the individual jurisdiction named in that report card can certainly use that information to compare the immunization rates by site and by vaccine with the rest of the state.
And this is Pam Sykes with Mercy. Something that Mercy has done that's been very helpful is to actually create a database that pulls in the vaccines from the state registry. We also receive claims from Medicare or CMS and the Medicare Advantage programs here in the area. That's all fed into the database, and then these reports are insight reports that the physicians can actually pull through our EHR to see what their rates are.
Great. Thank you so much. Appreciate that. Angel, is there anyone in the phone queue at this time?
Yes, we have a question from the line of Rick Shroud. Your line is open.
Hey, I'm a pediatrician in South Carolina, and when Dr. Kim was talking about Tdap vaccination rates, I think pediatricians are good at keeping immunization rates high for our patients. And when he was talking about doing the moms, in the hospital, we vaccinate most of the moms that just delivered with Tdap if they're not up to date on it. My issue is that the hospitals won't vaccinate the dads, and knowing that it's hard to get to the dads outside of the hospital. When they come in for the newborn check, the 2-week check, the 2-month check, we're constantly reminding the dads that they need to get it done. But if they miss that contact point in the hospital, the likelihood that they are going to go seek that out on their own seems unlikely, and it seems like the rates could be increased if we could get them in the hospital. I don't know if anybody else has success doing that in their hospital systems, so that I would have some ammo to go back to ours and say other places are doing this, but they keep saying that they're technically not their patients, so they can't access them.
That's a great point. If you do have thoughts on that, if you could jump into chat and respond with any ideas or strategies to help Rick, that would be very much appreciated. Angel, are there others in the phone queue?
There are no further questions at this time.
Okay, great. Thank you. I'll turn it back over to Gary at this time.
Thank you, Marilyn, and again, thank you to all of our wonderful speakers today. Next slide, please. We want to know what your key takeaways are that you're coming away with and how you plan to apply them to your own day-to-day work. As we move through the next couple of slides, can you please take a moment to share these ideas with us in chat? Next slide, please. We want to make these calls actionable for all of you. On the slide, you'll see a 2-part call to action for each of you. If you just want to review those 2 parts, we really appreciate it. Also, we encourage you to complete the post-event assessment. The link is displayed here on the slide and also has been posted into chat. Next slide, please. As we mentioned earlier, we would love to hear those topic ideas from all of you so that we can plan our future offerings as part of this venue. If you have any ideas or needs, please send your ideas through chat, or else you can email us at quincc@area-d.hcqis.org, or you can also provide that information in the post-event assessment. Next slide, please. And to ensure that you have the opportunity to engage with all of you again related to the actions and activities as a result of today's session, we want to invite you to join us on our next National LAN event, and that is on Wednesday, August 9th. Please note that the registration will be required as well. The link to register is posted here on the slide, and also Marilyn has put that in chat. And next slide, please. And we just wanted to share that we've gotten a lot of feedback, and based on that feedback, the Quality Innovation Network National Coordinating Center, or the QUIN NCC, will be launching a streamlined event schedule that will be rolled out at the beginning of June of this year. Overall, there will be a decreased number of virtual events, and the majority of the various types of events will be hosted on a set Wednesday of each month at a specific time. For the most up-to-date event information, you can visit Healthcare Communities, and that's where you can find all the calls listed. And next slide, please. And I just wanted to check if there were any last questions. I apologize for the pause there. If you do have any questions, you can still post them through chat, and we will catch them that way. Again, I want to thank all of our speakers for today, Dr. Cherie Sutherland of CMS, Dr. David Kim with the CDC, Dorothy Andre with TMF, Dr. Kevin King and Pamela Sykes with Mercy Clinic East, Nicole O'Kane with Health Insight Oregon, and last but certainly not least, Jeff Rust with Qualis Health. And of course, thank you to all of our participants for today. All of you have a great afternoon.
This concludes today's conference call. You may now disconnect.